Hello, I'm Magnus Ohman from Duke, and welcome to the cardio panel here at the European Society of Cardiology. At this meeting, we've had several studies being presented that are sort of focusing on two broad different approaches to prevention, either secondary or primary prevention, one being the more personalized, targeted approach, and the other one is the sort of more broad-based prevention polypill approach. And we've had interesting papers sort of talking about both of these challenges. Terje, Pederson, you're from Norway, you've worked in this field for a long time. What is your perception here? Are we going to give up that sort of personalized, targeted approach, or just say polypill is good for all, or is there much more to this?
When I first heard about the polypill and the whole idea introduced, I was rather skeptical. But I have changed my mind a little. I think that in secondary prevention, in the Western society where we have the resources, I don't think the polypill is the right way to go. Because in my clinic, where we practice preventive medicine, also mostly in secondary prevention, I'm seeing how much effort that are necessary to really fine-tune the risk down to the minimum. And I think the affluent Western societies can afford to do that. A totally different question is what we're going to do with the third world, where we have seen today in the PURE study that they are not getting the attention needed. And in that situation, I think the polypill is the right way to go.
Silvia, Priori, both from both sides of the Atlantic, one at University of Pavia in Italy and also now in New York with us. Tell us, where do you stand on this? Now seeing the large divide of the Atlantic between us, what are your thoughts on this?
I think that one aspect that the polypill may address also in the Western countries is the issue of the compliance, because even in Western countries, more and more the patients tend to have a very complex scheme of pills to take over the day. So I think that we still need to see the results of all the studies that are going on with the pill, that there is still the issue of what is inside the polypill and which flexibility of dosages is there. But the concept itself, may also serve some of the patients who are more reluctant to take medication for prevention, and especially that for the primary prevention polypill. So I think that the polypill has some advantage. Of course, it's more intellectually fascinating, the individualized approach. And from a genetic perspective, there is a hope that the genetic markers may become part of the scheme. So I think that it will be more a matter of an interplay between the two, attacking different problems and different patient preferences.
So actually personalized medicine for the polypill might be the non-compliant patient, which is actually, right. It's a very good point. I hadn't thought about that. Now, Terje, if you were to design a polypill for prevention, and let's focus just on the cholesterol part, because in a sense, polypill actually really goes towards hypertension and all the aspects, but let's just focus. If you were to do this, would you actually then have something that modified LDL, I presume, but what about HDL? What about fish oils?
It's much too early to talk about HDL modifying components in the polypill. I think we need to see results of clinical trials that really show that raising HDL with a drug is beneficial, and we have to wait a few years yet until we see results of large-scale clinical trials doing that.
And they're indeed large, right? 20,000
yes.
patients.
Well, the DAL outcome study has 16,000 patients, and the REVEAL study, which is going to use anacetrapib, will have 30,000 participants, and it will not be available for the results until maybe 2016-17.
So it's a long way away.
Yeah.
Well, I have to ask you another thing, which is really interesting to me. Many of these international trials now, and you have been leader of this field for a long time, many of these trials are carried out in Asia, eastern part of the world, they're not actually done mostly in our societies, the Western world or North America. So are the results as compelling even if it's carried out in a population that are not so focused on prevention?
I've been part of several studies that have involved countries in Asia, like the SHARP study in people with renal disease. And we are in the process of finishing the heart protection study 2, which is carried out in Scandinavia, UK, and China. And there are differences in populations in terms of tolerance to treatment. But I think what I've seen from the work, the scientific quality being performed in China and the rest of Southeast Asia, it's excellent.
So prevention is prevention then worldwide,
Absolutely.
which is actually, I guess, is a good thing to see this. Now, your perspective, having moved from Italy, and I'll anecdotally tell you about a patient of mine that had difficulty with her lipids, went to Italy for several weeks and then came back with the best lipids I've ever seen her have. I have to ask you, do you perceive that we think that we can do things with diet and other things that have a big impact?
Yeah, of course. You know, diet and lifestyle are the precursor of the polypill in a sense, are these basic approach that apply to everyone that can give a lot of results. So clearly, also the approach that the European countries are taking with the social medicine, who is trying to design policies for public health with a cost containment approach, are really focusing a lot on the control of the lifestyle. So I think that definitely the diet that is present in the Mediterranean countries is something that already makes a good contribution to primary prevention of cardiovascular diseases.
Well, and you point out that many times when we look at the health statistics for North America, there's nothing a whole lot to be proud of, and that's something we need to take heed of. You brought up earlier the fact that the polypill for the non-adherent individuals. Now, Terje, how do you feel about this sort of in the difficult to manage patients in the Western Europe? Is that, or Northern Europe, I should say? Do you feel that there's still a room for that?
I don't think that the non-compliance problem is particularly large in some parts of the world rather than others. Non-compliance is a universal problem, both in primary and secondary prevention, perhaps even more in primary prevention than in secondary prevention. And whether the population in third world would comply better to a drug which is not prescription, but you can get over the counter, I doubt it. I doubt it.
So you think it's really a worldwide phenomenon,
Yes.
which is really a key. And there's not a whole lot of research going on in this field right now, how we should manage compliance. You brought up the pharmacist. Tell us a little bit how that would work individually. So the pharmacist is employed. How does the model work?
Well, the model should adapt to whatever the healthcare system is, and definitely there would be differences between the more advanced countries, more rich country, and the underdeveloped country. In the underdeveloped country, I think the primary care is where most of the action is taken. In more Western countries, there is more the concept of the responsibility of the patient, so it may be distributed based on the recommendation of the physician to the patient, and the patient can then be handling the adherence and the compliance to that, while in third world countries, it probably will require a continuous medical or nurses presence to ensure that there is compliance, because probably the issue of primary prevention, treating something that you don't see and you don't perceive as a disease, is less well established.
Yeah, and of course there's a real development in North America with nurse practitioners, physician assistants really filling in the primary care model. And at least in our experience, the mid-level, as we call them, as opposed to between a nurse and a doctor, they offer a tremendous systematic approach to healthcare. Well, I think this discussion has been very helpful. I want to thank both of you for participating with us today. Thank you.
you.